Now that we have talked about the individual endocrine systems, what about their role in aging? As we have seen, the HPS axis and its associated IIS is a major player in the aging process, and modulation of which is associated with altered longevity. The other endocrine systems that we discussed earlier are also affected by aging, but likely do not play such a prominent role as aging modulators. Instead, they show a functional decline as a consequence of aging. The female HPG axis consists of hypothalamic gonadotropin-releasing hormone, GnRH, also known as LH-releasing hormone or LHRH, which stimulates the release of follicle-stimulating hormone or FSH and luteinizing hormone LH from the anterior pituitary. These hormones, in turn, act on the ovaries to stimulate the production of estrogen or estradiol and progesterone throughout the female cycle. During aging, estradiol and progesterone levels decline, which leads to a decline in the feedback inhibition and an increase in gonadotropin levels. One would think that this, in turn, would increase stimulation of the ovaries to produce more hormones, but it does not. Instead, the overabundance of gonadotropic hormones leads to a decrease in the levels of their receptors, further shutting down hormonal signaling. This aging-dependent decrease in estradiol production is almost entirely due to ovarian biology. At birth, the ovaries are filled with immature oocytes, which begin maturation at the onset of puberty, on average 1 oocyte per cycle. Over time, this lifetime supply of ovaries gets depleted, which affects the ability of the ovaries to produce estradiol and progesterone, with the associated effects on the HPG axis, as we just discussed. Thus, menopause is more of a programmed effect, a consequence of the regular developmental program of the ovaries. Certainly age-associated, but is it aging? This same program will proceed at the same rate even in humans with exceptional longevity, and will affect women between 40 and 50 years of age, regardless of their eventual lifespan. In males, the HPG axis consists of the same brain hormones, but now FSH and LH stimulate the testes, which respond with the production of testosterone by specialized cells called Leydig cells. Similar to females, in which estradiol and progesterone production declines with age, testosterone production in males drops off during aging. Leydig cells appear to be particularly sensitive to oxidative stress, and their age-dependent functional decline has therefore been linked to increased oxidative damage. Testosterone is a hormone with anabolic function, that is, a hormone that promotes buildup of material, such as the generation of cells and all the associated functions, such as strength, including muscle mass, bone density, cognitive function, and so on and so on. Thus, age-dependent loss of testosterone can explain, at least in part, many of the phenotypes of the elderly, such as loss of muscle tissue, grip strength, frailty, and even some declines in cognitive abilities. Likewise, levels of GH decline over age. Since GH stimulates the production of IGF-1, and IGF-1 is a major mitogen, that is, it stimulates anabolic pathways and cell growth, lack of GH in turn leads to a reduction of cell growth. Animals lacking GH usually show a dwarf phenotype. Many aging phenotypes can be traced to GH decline, such as an increase in fat tissue and obesity, and GH treatment can reverse them. This leads to a rather paradoxical situation, where individuals with low GH levels are likely to be longer lived, as we've discussed previously, but at the same time, decline of GH over age is associated with detrimental health outcomes. So what then about simply supplementing with these hormones, such as estradiol, testosterone, or GH? In fact, this is often done to treat some of the pathologic effects of the decline. Estradiol is often used in hormone replacement therapy, or HRT, for menopausal women. Testosterone is often used in a similar way in men that have drastically reduced testosterone levels. And GH treatment is often touted by so-called anti-aging doctors as a panacea for all sorts of age-related problems. You may have even seen ads in the in-flight magazines featuring this guy here who is promoting testosterone. While testosterone treatment and probably a lot of exercise did indeed lead to a loss of fat mass and an increase in muscle mass, he still looks old, doesn't he? So at best, it's just a way to stem the decline in one particular organ system. But the problem is not the best case scenario, it's the worst case scenario. What all of these substances have in common is that they stimulate cell growth. We have a word for that, for uncontrolled cell growth. We call it cancer. All studies using these substances found increased risks for the appearance of certain types of cancers, such as uterine cancers in women undergoing HRT. From a medicinal point of view, these supplementation regimes are only indicated when hormone levels are extremely low and the benefits would outweigh the risks. Antagonistic pleiotropy strikes again, with cancer as one function, anti-decline or anti-aging as another. In short, beware of the miracle doctors. The HPA axis stimulates the adrenal cortex to release two classes of steroid hormones, mineralocorticoids and glucocorticoids. These hormones control many basic metabolic functions, including fat, sugar, and protein metabolism. Glucocorticoids, furthermore, are the body's stress signaling molecules, preparing the body for a fight or flight response, including rapid mobilization of stored energy reserves. What is good in the short term, that is the escape from the bear that wants to eat you, is bad in the long run. Chronic exposure to these stress molecules, in other words, chronic stress, has detrimental effects on physiology and leads to reduced longevity. For example, Drosophila that are housed under crowded conditions perform worse on stress tests and have severely reduced longevity compared to the normal density housed control cohorts. During aging, the negative feedback loop from the adrenal gland to the hypothalamus seems to decline in function. Thus, once the adrenal gland is stimulated, hormone production may stay on for longer, leading to elevated levels of stress hormones and a greater potential for their damaging effects. Another class of molecules produced by the adrenal gland are the DHEA and DHEAS, the dihydroepiandrosterone and its sulfate. These molecules have no major hormonal function, but mostly serve as precursors for the other steroid hormones. Functions they have in their own right are mostly minor, such as regulating body odor or modulating certain metabolic intermediates, but they are tightly associated with aging, by declining significantly during aging to the point where they may even serve as true biomarkers and predictors of aging. Naturally, this consistent pattern makes these steroids attractive targets for supplementation, but thus far no strong evidence for or against such a regime has been obtained. And all the claims you may have seen in ads are even based less on evidence than the testosterone claims. In terms of thyroid function, Snell and Ames mice showed TSH deficiency. Hypothyroid rats are long-lived, and even in humans, lower thyroid hormone activity is associated with extreme longevity. Interestingly, TSH levels increase with age and are especially high in very long-lived populations. This seems counterintuitive at first, but appears to be an adaptive response of the pituitary when the thyroid is underproducing hormones. In an attempt to make more T3 and T4, more TSH is produced by the pituitary. Since thyroid hormones regulate basal cellular metabolism, lower T3 and T4 activity reduces basal metabolic rate, leading to decreased ROS production and decreased cellular damage. On the other hand, hypothyroidism also is associated with fatigue and weakness, weight gain, and difficulties in regulating body temperatures, largely due to the decreased metabolic rate and energy production. These symptoms can fairly easily be treated with hormone supplementation, but just as in the case of IAS, we have a rather paradoxical trade-off laced situation. Reduction in thyroid hormone signaling extends longevity, likely through mechanisms associated with lowering basal metabolism, but this lowered activity also leads to pathological phenotypes. Health and longevity may simply be the two sides of the very same coin here. One of the hallmarks of aging is an increase in insulin resistance, the inability of cells to respond to insulin. Insulin action leads to clearance of glucose from the bloodstream, either for long-term storage, for example as fat tissue, or for short-term energy production in the muscle especially. To complement these actions, insulin also stops the liver from making glucose and inhibits fat breakdown. Due to the multitudes of insulin activity, insulin resistance always has to be assessed on a per-tissue basis, and likewise age-dependent insulin phenotypes may depend on which tissue is particularly affected. Recently, the view that insulin resistance is due to aging itself has been challenged and supplanted by the idea that it is rather a pathological process, age-associated for sure, but once again, not caused by aging. Rather, the biggest contributing factor to a decrease in glucose tolerance and an increase in insulin resistance with age appears to be lifestyle. As people age, their amount of physical exercise decreases, which is often coupled with poor diets. Especially in affluent societies, sedentary and hypercaloric lifestyles contribute significantly to insulin resistance, obesity, and all sorts of associated phenotypes. In fact, for the first time in over 20 years, U.S. life expectancy at birth has declined slightly, most likely as a direct consequence of these altered lifestyles. Check your knowledge. Compare and contrast the age-dependent effects of the different endocrine pathways. Explain trade-offs observed in endocrine signaling, especially with respect to aging and metabolism. Differentiate between causative and associate functions in endocrine signaling.